All right. Good morning. So let's see. First housekeeping item, parking lot item. The quiz for week 11. You guys did well. The average was like a 90%. So congrats on that. Good job. And let's see. The recording was posted. The recordings go on the lesson page for my lectures. If I do my YouTube recording, I post it on the lesson page at the top. So that was posted. So you had that for the quiz. Your SCI, spinal cord injury, care plan, care map, or case study, sorry, is due by midnight tonight. So if you have questions, let me know. Remember to include your sources. You want to include the sources throughout and then have like a reference at the end. So if you haven't done that, you might want to resubmit that to make sure that you don't lose that 1 point for the sources. And the ones that I've seen so far, you guys have been doing a good job with. Okay, took care of that. There will be a quiz this week, the week 12 quiz. It's 10 questions. There are 5 questions on COPD and cystic fibrosis. And then there will be 5 questions from today's lecture using the exemplar of stroke. And as I go through the lecture, I'll try and point you in the right directions. The retake for the maternal newborn is today at 1:30. I have not sent the Zoom out. I will do that after lecture today. It'll probably actually just be the same Zoom, but I will get that set up for you. So if you haven't let me know that you'd like to take it, please do so. I think we have about 8 people, so I think that's great. So I will post that Zoom. And then what else? And I think that was it that I had. Any questions on other things? Because it's Monday and week 12 and questions, comments, concerns. Everybody's tired. I just went through a 3-hour curriculum meeting. It was very informative, but it was long. So we're trying to educate ourselves as well. All righty. All right, so if people are okay, then we'll just get started with, with the lecture. Do we know our instructors for the fall yet? So in 3rd semester, it's going to be Mrs. Davis and Mrs. Diamond. And I'm not sure who the other clinical instructors will be. My guess would be Mr. Cebellino. And probably Ms. Dupree or Ms. Dupree Parker would be my guesses. And it would be Ms. Davis and Ms. Diamond for the lecture portion, the course portion. And then they are also in clinical with the addition of Ms. Dupree and Mr. Cebellino. And again, those are my best guesses. That has not been confirmed as of yet. And I think Mondays and Thursdays for lecture and Tuesday, Wednesday for clinical, but again, not been confirmed.
I think maybe I might need some help with this question because I think some other people might know exactly what the name of it is.
Okay.
But there was like a document that a few groups were waiting on for our community project. I'm not sure, maybe Claudia.
So what's going on with the community projects is I've had 2 groups approach me to say that they have the opportunity to actually complete or implement rather their community project this semester as opposed to in 3rd semester. So that doesn't necessarily put you ahead or behind, but if the opportunity is there, the feeling was that since it is COVID right now and we're not sure what opportunities, could be hit or miss. I emailed to Claudia last night or this morning, I don't know, whatever time it was, the draft for the third sem. You know how you have for this semester, the second semester one? I emailed Claudia the third semester one. It's the draft because it has to be made into the, actual. So Claudia got it. So whatever the other group is that I need to send it to, please let me know and I can send you that as well. It basically lays out what you need to have for your paper, and it's not a necessarily a presentation that you're doing. It's like a poster board like you would do at a conference, right? And so you're going to go out and kind of present your community, what your question was or what led you to your project, and then talk about your project. And then you guys will actually, I think, if it happens during this semester or over the summer, you would in third semester then kind of be able to evaluate a little bit. Like, in other words, if you participated in a vaccine clinic, then what were the rates in your community? Did you see them go down, or how many people were actually vaccinated, or something to that that effect? So whoever the other, I honestly can't remember the other group, but let me know and I can send that to you, and I will Clinipal. So Aaron, I'll email it to you then. Let me write that down.
That's fine.
Yeah.
Aaron, email proj 3. Okay. So hold on, Whitney, let me get through community project. Right, so at least that will lead you in the right direction. You still must complete the second semester one as is for now. And then when you're in third semester, you will have to complete the third semester piece of it as well. But at least you know the direction to go, or what's going to be asked of you in analyzing once you implement and that type of thing, right? Okay. I know for this last cohort, they didn't, I don't think they implemented in third semester because COVID was so all over the place. So I think they're implementing now in fourth. But I think you guys will be fine moving forward. There's still plenty of time to reach out to communities and figure out solutions. A little off topic, but will we be able to choose our clinical group next semester, or what hospital we want to be in AM PM? I have no idea. I haven't looked at third semester on pause. Does it say, can you wait, first of all, can you register yet? No.
No, we can't.
No. Okay. So when registration comes up, my guess is, actually I can pull it up and pause right now, probably. Because I know for first semester, there's no information. It just has sections listed. It doesn't have instructors, nor does it have times listed. So let me just look and see how it's listed. My guess is it will be, well, let's see, this is new curriculum. So it will be mostly med surg, and then you would out rotate to some mental health, maybe some Jerry, and then as well as community. Forgot, almost put in 43 instead of 66. There we go. Community out rotations. So let's see, let me do this for you. So this is what, can you see pause? I've got pause up on my screen. Yes. And so these are the sections, dates and times to be announced, faculty to be announced. 1, 2, 3, 4, 5. That's not enough people. That's not enough sections. Right? 7 times 5 is 35. We need one more section. So I'll let them know they need one more section. But it will be the same thing. You'll meet for lecture, and then it'll be, these would be your clinical groups. So right now I don't know who would be, I don't know the answer, sorry. But that's what pause will look like, at least right now.
Okay, thank you. That we wait until we know more, or
I don't think you're going to know more. I know first, I don't know when when you're actually able to register. And I don't know. I don't know. I honestly don't know. Like I know what I'm for first semester. I know what I'm teaching. But I don't know like how much, like my percentage of things. And I also don't know, like for clinical, I don't know where I'm teaching. So like people know they're teaching, but they don't know the specifics yet. So even if I knew, I couldn't tell you. I wouldn't be able to tell you because I don't know. Okay, whoa, hold on. Raul had one, hold on. Will any incoming students change the group dynamics? I believe there's at least one, if not two students that may be coming into third semester from a previous cohort. And the way that that might change the dynamics is that they did not start in the concept-based curriculum as you did. They started in the legacy curriculum. So there may be some, you may need to support them with that. And then I don't know about Clinica next semester. I don't think so. I think we're kind of beyond that, I'm hoping. Right, because the registration dates, everybody's different with priority and all that when your dates are. And so I don't know. But my guess is it's sort of a blind registration. It would be SVMH and Nativna. Again, I'm not sure because normally it's Natividad only. It could be SVMH. We're still waiting to hear what our clinical partners are allowing us to do, you know, where we get to be, what the out rotations are, how many students we can have, and that kind of thing. Trust me, I wish I knew more as well. I don't know if that helps or just makes it more confusing, but if I knew, I would let you know. What else? No? Okay. And I did put, when I posted the SCI video, I think I put like at 17:15 is where the lecture actually starts. So I can do that when I transcribe this one over as well. That was Kelly's suggestion. So I did, I remembered to do something. Yay. Any questions on the case study that you're having so far? That's going well. Like I said, the couple groups that have done that have done a nice job.
With the upcoming assignment that we work individual or in groups, can we also have 3 to 4 students in our group?
I had I think I had put in pairs.
Okay.
Because I would kind of like that to be more individual and then you kind of check on each other, or because it's a right-sided, left-sided, maybe one does right-sided, one does left-sided or something, you know, like that to keep it a little more in check. You can still do it in individually if you like. I just think it works better. Oh gosh, did I even add that in there? Yes, I did. I think it just works better dynamic wise to not have too many people in that one, in that particular assignment. Make sure I have it all there. 12 cases. Right. Okay. Got it. And then, if you are taking, remember to turn in your, if you are doing the retakes, remember to turn in the reflection. Let me do this. Right, so you want to do, and again, concept map is a general term, whatever works for you to help you remember the information. So you're looking at a patient in the acute phase of a right hemisphere, right brain stroke, and a concept map, again, or whatever works for you in the rehab phase of someone that's had a left hemisphere, left brain stroke. Okay, so there's 2 separate ones, and then it tells you what you need to include. And you may work individually or in pairs. One person can submit for the pair. And then that gives you kind of what to include. So basically, you know, signs and symptoms, because they're different, right-sided versus left side. And then maybe things are, you know, the progressed in rehab than they were in the acute. Medications may be different, acute or rehab. Diagnostic testing that you would be doing potentially. Did I make that? I think I said 3. Yep, 3, sorry. Change that. Let me change that right now. It helps if the instructions and the rubric actually match. So sorry about that. Slow today. And then you want to make sure that you have a client problem, goal, and nursing intervention. Just one for each. And I wanted to speak to at risk, because some students were having questions about at risk nursing diagnoses. So if you choose to use an at risk for this particular assignment, just use it for one or the other, not both. And then when you're choosing an at risk client problem, if they're at risk, they don't have an as evidenced by yet, because if they have an as evidenced by, if you're seeing it, then they already have it, then it's an actual problem. So it should just be whatever the, risk for perfusion or what, whatever it would be related to, and then boom. So I just want to clarify, because I'm not sure that I think we did it at some point, maybe last semester, some point, but I know a lot of people are correctly choosing, right? Somebody's at risk for a seizure, right? But if you're seeing these things already, then they're having a seizure. There shouldn't be as evidenced by. That would be, the as evidenced by would probably be the risk, right? Because if you think they're at risk for a seizure because it'd be related to an increasing blood pressure secondary to preeclampsia, because secondary would be the medical diagnosis, but there's not an as evidenced by, or they have had a seizure. Does that make sense? Ish? Yeah, okay. Go back to home. And go back to the lesson. And I think I made that one due Thursday by midnight so that it was done before you move on to COPD and cystic fibrosis with Dr. Whitmore. Okay, so we are looking at, again, perfusion, tissue perfusion, intracranial regulation, looking at blood flow, cerebral blood flow, and how that can affect sensory perception, mobility, cognition. And we're going to look at it in terms of the acute stroke phase, but also focusing more on the rehab side. So I would probably, when we get to that point, I will probably ask those of you in ARU to share any stories that you have. If you've had patients that are rehabbing after stroke, like what have you seen? What does PT/OT work on? What are some of the risks that you're, afraid could happen, things that you're on alert for? And so we're going to be able to define the difference between ischemic stroke and hemorrhagic stroke. We're going to look at different risk factors, which are going to oftentimes go back to our hypertension risk factors that we had from first semester when we used hypertension as our exemplar. And then, excuse me, how do we know that there's an issue? What do we see? There's some diagnostic procedures that the physician can order. What are the clinical manifestations? Looking at right versus left-sided, because there are different responses that you're going to see. And then talking about psychosocial responses, family members, people involved in the care. And then what interventions and collaborative interventions, working with the team, what can we work on? What are our interventions to stabilize the patient, to, looking at different medications, not in great detail, because I believe you would have gone over like the anticoags, antiplatelets in pharm. Or was that was first semester maybe? So review those. We'll mention them a little bit. And then talk about PT/OT, if there's any surgical procedures that we can do. And then again, how to support the family. So let me go through the pictures here, and then we'll go to the PowerPoints and kind of talk about patients and how they will present. And feel free to ask questions, or if you have stories of patients to share, that's good as well. So this is a potential type of concept map. I thought it was kind of nice. So we have AJ is a 66-year-old white woman, Caucasian woman. She woke in the middle of the night and fell when she tried to get up and go to the bathroom. She fell because she was not able to control her left leg. So her husband took her to the hospital where she was diagnosed with an acute ischemic stroke because she had awakened with symptoms. The actual time of onset was unknown. And so she was not a candidate for the TPA. So ischemic versus hemorrhagic. What do you think a hemorrhagic stroke would be?
A bleed.
A bleed, hemorrhage, right? And so then what would an ischemic stroke be?
A block.
Yeah, like a block or something, the circulation's cut off, right? No blood flow, good. And then if she didn't have control of her left leg, which hemisphere do we think that the stroke occurred on?
All right.
The right.
The right side, because it's the opposite, correct? Yay. All right, so the medical diagnosis is the acute ischemic stroke, right? The key tells us that down here. And then the risk factors that this particular patient has is she looks like, if she has a history of left-sided weakness, tingling 3 months earlier, that might have been what's known as a transient ischemic attack, right? What they call mini stroke, TIA. She's overweight, and she reports not taking her high cholesterol drugs for weeks. So those are some of the factors that put her at risk for this stroke. And then we look at the clinical manifestations. What are we seeing? What is she presenting to us? And so she has left-sided numbness and weakness. She's alert and oriented, but she's a little slow. And she has left-sided hemaniopsia, which we'll talk about. I have some slides about that. That has to do with her vision and only being able to see on the same side out of both eyes, which is going to lead her to some neglect of the affected side. So if she is, if she's weak, so then some of our, they call them nursing diagnoses, but we would call them a client problem, and then nursing interventions or outcomes, right? So if she's got weakness, that's a mobility issue, right? The client problem is impaired mobility because she's having difficulty moving. And then we're going to put together whatever our, I think I put little, so nursing outcomes classification. This doesn't tell us specifically what our goal is. That's up to us and the patient, right? But that's where our goal or what our expected outcome or goal would be. And then our interventions, we're going to collaborate with, PT, OT, ST. We're going to assess the readiness for different programs, help her, educate the family on how to practice these exercises, make sure she has a restful environment, right? So this is what she presented with. This is our client problem, which is the mobility. We're going to have some goal, like she'll be able to, walk so many steps, or she'll attend all her physical therapy appointments, or something like that. Or maybe it's not even walking, maybe it's leg lifts or something, some type of exercise or range of motion as our goal. And then these are the things that we're going to do in order to help her reach the goal. So she's alert and oriented with a slow response time, right? So she's got some impaired verbal communication. So would be communication would be our concept. What other concept could this fall under? Maybe. Besides communication, also starts with a C. Has to do with thinking or your thought process.
Consciousness?
Cognition.
Cognition, right? We hope that they're conscious, yes. But in terms of the concepts of those that list of Giddens concepts, right? Cognition would be potentially another one, because communication, according to Giddens, is more of the nurse to nurse and health team communication. So this might fall under cognition, but I like communication as well. So we're going to set some goal for her regarding cognition or communication. And then the interventions, right? We're going to listen, use simple words and short sentences, positive reinforcement, lots of prompts and reminders because she's probably forgetful, right? So maybe, she remembers how to do a particular ADL, she remembers how to brush her teeth, or she's able to repeat back a sentence or remember a 3-word list or something like that. And then these are the things that we're going to do to help her reach that goal. Is this, are we following along? Does this make sense? Hopefully this is helping a little bit. Okay, thanks. All I have is Shannon, Kelly, and Whitney right now. So you guys are my eyes. And then the left-sided Hemorrhagic. So unilateral neglect, I guess that would be, I'd still probably, well, let's see, vision. I'd put that under sensory perception because it has to do with vision. And so it's an awareness of the affected side. In other words, there is no awareness of the affected side. So like her left side, that's my right side. Her left side is neglected because she doesn't think about it because she can't feel it and there's no sensation. And so that side gets neglected in terms of anything. So you want to try and cue her as much as possible or have her try to remember to do things with the affected side. You also want to make sure that you're positioning things on the unaffected side. So like, for example, it says the TV remote or reading materials that you want to place so that she can see them. Because if you put something all the way over on the left, she's not going to be able to see it. So you want to put things on the other side. And this will be in the PowerPoint as well. But just to sort of get you thinking about, right, this is all our patients. What do we see? What can they do? What can they not do? What do we want them to do? We set a goal and we do our interventions. Or you work it backwards, right? I did this because, well, why did you do that? Well, because of this. Well, why did you do that? Well, because of that. Right? We put it on the right side. Well, why'd you do it on the right side? Well, because she can see on the right side. She can't see on the left side. Well, why is that? Right? And you work your way back up. So different client problems. So I try to put it in terms of to help you guys with how to put them into the concept categories. And so here's your note. If you have at risk, then there's no as evidenced by. If you have as evidenced by, then it's no longer a risk, it's actual. So what, so we have perfusion, right? Mobility. So one of the old nursing diagnoses that we use was activity intolerance, or this under functional ability, unilateral neglect or disuse syndrome. So instead of using those terms, it would fall under functional ability, or maybe even safety, right? There's several different categories that some of these things could fall into, because who's had a patient who's been at risk for aspiration? Probably lots of people, I'm guessing, right? They're at risk for aspiration. Yeah. And so, yeah. So what concept do you put that under?
Safety.
Right, safety. I mean, you could put it under nutrition maybe, but it's really a safety issue, right? And so then what are some things that you do if they're at risk for aspiration? What are some nursing interventions that you do?
Keep the head of bed elevated, have suction available, assess their, gag reflex and their swallow capabilities.
Good. And then what about impaired swallowing? That's sort of in the same category, right? And so if we have somebody with a stroke, they potentially are going to have some difficulty with swallowing, right? So that's, even though it sounds like it may be nutrition, maybe mobility, it's really safety, right? Because we don't want them to choke. So what are some interventions that we can do for impaired swallowing?
Keep them upright during meal. Give them like a little bite.
Yes, little bites, right? That's a key point, little bites. I like Brittany's have speech therapy, because speech therapy is actually the one that does the swallowing evals. It's not PT or OT. Speech therapy comes in and does that. Head of bed elevated, right? Diet changes, maybe thickened liquids. That
Also eat slowly.
Yes.
I watched a speech therapist do a swallow eval. And so I was training him to take smaller bites, but also go gross. It was like one spoonful at a time. And it kind of cut that muscle memory of just shoveling food in your mouth. It was one at a time, put it down, swallow, and then repeat.
Nice. That's perfect, Aaron. That's a great example. Soft, high calorie foods, protein, right? Nice. It's nice when you see it in practice, right, Aaron? Like you see it and you go, oh, okay, I get it, right? I love that. So one of the other things that might come under stress and coping. So we talk about, educating the support person, but what about the strain that's put on the care provider, their support person, right? And so maybe, yes, we're focusing on the patient, but maybe the patient's pretty good, but their caregiver is burnt out because they've done all this education. They've been getting the home ready for discharge for the patient to come home. So sometimes we want to look at the caregiver, the strain on the caregiver, right? And that would fall under stress and coping. Visual disturbances may be under sensory perception. We talked about verbal could come under verbal issues under communication, maybe cognition. I don't think I added cognition. You guys can add cognition. So does that kind of help a little bit? You've got tissue integrity, right? Family dynamics, nutrition. So I was trying to put it in terms of the Giddens concepts. Because if you go and look online about a care plan for stroke, you're going to see unilateral neglect, disuse syndrome, aspiration, those types of things. So I want to put that in context for you. This is a link that will take you to CDC and their information page on stroke. Acronyms kind of change all the time. I think this is one of the most, or be fast is the other one, right? Like, is there facial droop? Does the face look even uneven? If you have them hold the arms, they're going to get the droop. One of the arms is going to drop. Do they have slurred speech? And then time, like call now. Even if you're not sure, you call now and get 911 there. Because why is time so important if you think that they had a stroke?
You can give them the medication that can help with the TPA after 4 hours.
Right. Nice. So you EMTs out there, like what kind of experiences can you share in terms of getting a call and they think it's a stroke and you're bringing the patient to the hospital?
It's generally just time and then dual IV access, large bore IV access.
There you go. I like that. Dual bore IV access and time. And then, so you would be asking those assessment questions then in terms of when do you think it started?
Yeah. Oh, go Emily.
I was going to say, yeah, we asked the family once the time they were last seemed normal. So it's hard if it's like, oh, I put them to bed at 10 p.m. And then when I went to go wake them up for breakfast at 7 a.m., that's when there was a problem. Then basically that stroke could have happened anytime throughout the night. Maybe it was only an hour ago, but because they were last seen normal, what is that, like 10 hours ago, then we have to go from that time, which kind of makes it like shortens their time as far as treatment. And then sometimes depending on what's going on at the ER, like at SEMH, they'll have us just take them directly to imaging in the ambulance instead of having them go through the ER first.
Right. I think, well, if it's a stroke center, you'll hear code stroke come over. And then that generally means that the patient is coming in and probably going directly to CT. And so everybody's like on board and ready to receive the patient. And why are they, so you all know what a CT is, I believe. And then why are they doing a CT? What is the purpose of doing the imaging?
To know if it's a bleed or a block.
Yes, I love that. Bleed or block. Look at that. That's even like alliteration, right? Bleed or clot, right? Bleed or block, bleed or, I love it. And why is that important?
That's dependent on how they're going to treat it.
Yes. And so, so explain that more. What is it? What are
If they have a hemorrhagic stroke, you don't want to give them anything that could cause them to hemorrhage even more. And then if you have a block, you'd want to treat it differently than you would a hemorrhagic stroke.
exactly, right? We're not going to give TPA if it's a hemorrhagic stroke. They're already bleeding. We don't want them to bleed more. But that takes time to get all that set up. So if the ambulance, right, here's also interprofessional, right? EMTs, what do you call in immediately? What's an SBAR, or what do you give to the ER to let them know you have a stroke patient coming?
As soon as we suspect it's a stroke, even if we're still on scene, we call them and give them a stroke alert. And so we'll give them the age of the patient, last known normal, stuff like that. And then we call them when we're about 10 to 15 minutes out from the hospital and give them the info from like the 12 lead, more vital signs, pretty much any other information that we've gained while we're en route. Obviously, depending on how far away you're coming from, right? If we're coming from Soledad, we get a lot more time to do stuff. If we're coming from a couple miles away, there's not that much time, but that way they kind of know exactly when to have people outside ready for us as well.
Right. So back in the dark ages, in the ER, you didn't know what you were getting. Like you just kind of roll in or maybe, but because evidence-based practice has shown that the timing is so vitally important and the determination of the type of stroke, type of injury, that's why we now have stroke hospitals and code stroke so that we can be ready. Everybody knows their job, what they need to do and has their part. It's like a code blue, right? It's a code stroke. Everybody knows exactly what they need to do to be prepared for the patient. This particular link should take you to the stroke scale scoring. This is like an actual one that you would actually, it'll add it up for you, right? Level of consciousness. So are they unresponsive? Do they arouse to minor stimulation? And then, so you guys can play around with that. It actually will add it up for you. And then once it adds it, it should be 11 items. And then it should give you, let's just try it out here. So, performs one task, right? You're gonna ask them tasks. What's their vision like? They can't see. What's their partial paralysis? I'm just hitting buttons. So the arm drift is what they're talking about, left arm versus right arm. Just keep, and they're looking at right versus left. And this is what you're assessing as the nurse. And then one more. And so then it actually will give you the number of points, and it should, if I'm not, yeah, then it will tell you like what to do and the management and critical actions. So I thought that was kind of cool to play around with. If you would rather see it on paper, here is that scale on paper. And then if you look at the stroke severity, right, what score did we just get on the previous one we did? Anybody that was paying attention? Yes, thank you, Francesca, 22. So where does that put us under stroke severity? Severe, right? So that's what this information will give you. And so it has the same thing, and you just, and then this one's nice. This is actually from charting from Providence. So this can show you over time, right? Because date and time and initials. So if you're doing this every 4 hours, every 2 hours, you can see if they're progressing in a positive or if they're declining, what's going on. Does that make sense? Yeah. And then I think we've talked about the Glasgow Coma scale at some point, but I like this particular graphic because I think it's straight and to the point. So we're trying to figure out how, do you guys use this, Emily, or you, Isaac, the guys that are EMTs, do you do Glasgow Coma scales? Because I just looked at it, put EMT and paramedic prep.
Yeah,
Isaac
we
said
do.
yes in the chat.
Yeah. Oh, there it is. Thank you, Isaac. Right. So is it spontaneous? Do they not have it? And so then again, the higher score, you have to kind of know which ones are, what the higher is a higher score better or worse. So for the Coma scale, the higher score is better, but for the stroke scale, the higher score is worse. So you kind of have to keep that in mind. But this is a lot of assessing. This is a lot of what nurses and EMTs, but nurses, right, we're going to be assessing. These particular links will take you to, this one's an article on neuroprotective agents in the ICU. So this was kind of interesting. I'm trying to think where, and we're looking at it in terms of stroke, not the other ones, but you know, what kind of use, the different types of medications, like how can they help? So this just gives you a table. You do not need to know this. Oh, thank you, Isaac. Yeah, 3 is the lowest. Yeah, a wooden kitchen table scores a Glasgow Coma scale of 3. I love it. I love it. It's kind of nice to know that, you know, you don't need a 0. You don't need to know this. This is just for your information, but this is what they're looking at, what different types of medications or neuroprotective agents could be used and what their effect is. This particular link will take you to Heart and Stroke website, and actually talks about the TPA, the tissue plasminogen activator, for patients, again, who have an ischemic stroke. I think 3 hours, I keep seeing different literature. Here's a good PICO question. Is it 3 hours or 4 hours? Like, which is the better, is the better time frame? It's generally 3 hours, but depending on their age and other information, they might go as far out as 4.5 hours. This one's in Canada. Sorry, I just like the way it was set up. And then again, you're going to look at your blood thinners, right? Your antiplatelets and your anticoagulants, right? And so antiplatelet drugs, I think clopidogrel is probably one that you see a lot. What's the other name for clopidogrel?
Plavix.
Plavix. Good, Kenya. And then your anticoags, right? Those are the ones that are going to be, you're going to see your heparin, your warfarin. You might see enoxaparin. So those are basically the meds that we're talking about. And acute care would be the TPA, and then as you move along, it would be the Coumadin and the heparin, sorry, and then the Coumadin. And then this one gives you a nice look at the TPA. Again, it's more another article. This one actually specifically goes into the indications and the types of strokes and how it works and giving it. It has all kinds of information in there that you might find useful. And then I did put in some pictures to kind of try and if it's helpful for you, I like these ones. It goes over the left-sided cerebrovascular accident. So left brain damage, right body weakness, right CVA, right brain damage, left body weakness. You need to know key points of the differences between the left and the right sided stroke, things that you're going to see, not just motor signs and symptoms. So in other words, if it's a left hemisphere stroke, you're going to have issues on the right side. You're going to have the paralyzed right side. However, you're also going to have impaired speech and language. You're going to be a little slower about things. You're going to have vision problems. And you're actually going to be aware that you have these problems, and you're going to have impaired comprehension. That's why I like this 2 + 2 = 5. What do I eat with a spoon, right? It's like, you're like, I don't know. And then if it's the right hemisphere cerebrovascular accident, yes, the left side is going to be paralyzed, but you're going to have spatial deficits like depth perception and where you are and things around you. You tend to minimize problems. You don't have much of an attention. You're a squirrel, which I am anyway. I don't know. But this one has impaired judgment and impulsivity. And those are key components of a right CVA, is the impulsivity. Whereas with the left CVA, you're slower. It's a little slower, right? So those are some key things that you need to know about right versus left. And you're going to do that in your concept map as well. In terms of functioning and the affected or unaffected side, you want to assist the client to get out of bed. It kind of makes sense, obviously, on the functioning side, right? You're not going to get them out of bed on the side that doesn't work. You want to get them out on the side that's functioning, and then they can help mobilize the affected side. And again, these are just more ideas of what exactly. Here's a transient ischemic attack, like a mini stroke. The key here is that it lasts a few minutes to 24 hours. It's not a long-term thing. You can have over time long-term effects. My mom was telling me at one point she was out with her boyfriend at a bar, and remember at the time my mom was like in her 80s and the gentleman was in his 90s, and all of a sudden he started slurring, like she couldn't understand what he was saying. And eventually we figured out that it was a stroke. And so they went to the hospital, and it was a transient ischemic attack, but he was starting to have more and more of those. And so we were afraid he was going to get a stroke. So you kind of have to look at the patterns and really look at what's presenting. Here's your difference between hemiplegia and hemiparesis. So anything with plegia, right? What we learn about SCI, right? Spinal cord injury. Plegia is paralysis, whereas hemiparesis is weakness. So you may see these terms in different notes that people are making. And then this is a really confusing one, but it's got a whole lot of information on it. It gives you, what a TIA is versus the cerebrovascular accident, how you're assessing that. It gives you different risk factors, which we're going to talk about in the PowerPoint. So it's got reversible ones, partially reversible, non-reversible, different diagnostic tests that can happen. So you're going to have to go back and look at that full neuro exam from last semester, or if you weren't here last semester, review the neuro exam. And then there's your airway, right? Airway, this is increasing intracranial pressure. So we want to decrease that. We're not going to focus as much on that right now. It's more the mobility, elimination, cognition, those types of things. And so you just have those available. Hopefully that helps. If you're a visual person like I am, I like those little ones. All right, any questions so far? Everybody's still with me? Even though I can't see you. I have Kenya, Erin, and Emily in front of me right now. In front of me. We good? Questions? Erin, thank you. 3 thumbs up, yay. Thank you so much. All right, so we're gonna move on to the stroke PowerPoint. Make sure I'm good on time. If it will load. There we go. So, so we're talking about, like, these are a lot of interrelated concepts, right? It's perfusion, intracranial regulation, cognition, sensory perception, mobility, oxygenation, like it's a lot of different things. And so we're supposed to, these are the objectives, right, which we looked at from the page up above. So those are just listed there for you. And then we're going to, that's a lot of objectives. There we go. So in case anybody wanted it, picture of a brain. If you guys need to go back and look at brain anatomy, right, left-sided, that type of thing. Iggy has some good resources in there. Feel free to do that. But it shows you where like the speech centers are, reading comprehension, that type of thing. So that's just a brief overview. And again here, ooh, the picture cut off, sorry about that. The nerves, we talked about this with spinal cord, right? The central nervous system, the peripheral nervous system. And so when you have a stroke, then you look at this one. Again, this is just I don't know, where's Hugo? This is stuff and you can help with that, right? So things cross over from the one side and they cross over to the other side. And that's why if you have right-sided, it affects the left and vice versa. So these are what the arteries look like in your brain, the cerebral arteries, lots of different lots of different ones. Don't need to know the names, don't need to know all that, but what the area that we're going to concentrate on, where the majority of strokes happen, is in what's called the circle of Willis. What are you talking about, Willis? Nobody knows that anymore. The circle of Willis. And so this gives you, this shows you right here where that is and the different arteries that are there. We have a lot of arteries. There's a lot of places for error here. So we're talking about blockages in the brain. So 5th most common cause of death, can lead to long-term disability. I mean, 800,000 people, the permanent, the sequelae just is amazing. You can get strokes at any age, but most are in, the majority would be over 65 years old. And it's a lifelong impact for the patient and their family, their support people. And so we're back to health promotion. Yes. Okay. Thank you, Amanda. Okay. I feel better now. And so risk factors, we're going to go back to the hypertension, right? So, and the health promotion, if we can keep the nutrition, make sure people are taking their medications and stress and all that, right? So prevention and teaching. And so we're going to look at the risk factors. If you can do that, that's great. So age, right? These are not the non-modifiable ones, right? The ones that you can't change, the person can't change how old you are, unfortunately. And so over 65, the more prone you are to having strokes, more common in men, but more women die. Higher incidence in African Americans. And then there is a possibility that there's heredity based on the genes and the lipids, inflammation, or if they've had other cerebral vascular occurrences, you're more likely to have one. And then back to our modifiables, right? 90% are the inflammation is huge. Yeah. 90% of strokes are a result of modifiable risk factors, right? So the hypertension, heart disease, your cholesterol, smoking, huge thing. Like my husband's going to be 65 in a month and he smokes and he's got hypertension. I'm like, he's a stroke waiting to happen. I'm like, honey, he is, however, not obese, which is good. And he does exercise several times a week. So drug and alcohol abuse, sometimes just from drugs, you can get a stroke just at that point in time. Poor diet. If you have migraines with an aura, you're at increased risk for stroke. And then there you go, Hugo, the inflammatory conditions. So here's a question for you. As one of your assignments, you're assisting an RN with health screening at the health fair. Which individual is at greatest risk for experiencing a stroke? You can put it in the chat if you want. So you have a 46-year-old female with hypertension, oral contraceptives, a 58-year-old white male, total cholesterol of 285. C seems what people are going for right now. A 42-year-old African-American female with diabetes who has smoked for 30 years. Or D, a 62-year-old African-American male with hypertension who is 35 pounds overweight. So I saw a bunch of C's and now I see some D's. I changed to D. I don't know. We went to the next question, Brittany. So talk to me. What's your thought process on C versus D? I feel like people went, oh, A and B. No way. So we got down to C and D. Talk me through your process there.
It says that stroke is more common in men than women. But they both have factors, so I don't know. I'm torn.
We know that African American are at risk for that. So they're both African American. Is more often with male than female, but with DM, I think they are 5 times at risk. That's why I should see. So.
Gotcha.
Yeah, I'm along the same lines as Armel, with it being diabetes, which is 5 times, smoking for 30 years, which that's a long time smoking, and a lot of potential for harm in those in those vessels up there. And then also African American. And yeah, I mean, that's just what I saw.
And what about people that are thinking D?
I initially went with C because the smoking for 30 years was like, that's kind of where I got stuck on. But I think because of the fact that it's a male, that automatically gives him an extra like risk factor or like a little check mark compared to the female.
Okay.
Also, he's closer to 65, and hypertension is also a risk factor, and he is overweight. I don't know.
Anybody else want to weigh in? I love the thought process. The thought process on both is not bad. Which one has, I guess, more factors? Brittany's saying there's more factors in D. So if you had to do your checklist, which one had, well, they both have factors, right? But so break it down in age wise. Let's take each factor, right? So we have a 42-year-old and a 62-year-old. Which one is more at risk?
62.
62. We have an African American, so that's equal, right? We have a female versus a male, which is more at risk.
Male.
Male.
And then we have diabetes versus hypertension, which is more at risk. Did it say 5 times more? Oh, 5 times greater risk. Yes, it did. Sorry. Hypertension's at the top there.
I want to say hypertension.
For a stroke, probably hypertension. And then the smoking versus the overweight, even if you gave smoking to the woman, you'd still be at 3-to-1. Does that make sense? Did I lose people?
No, that makes sense.
Okay, so, right. So older and male with hypertension beats 42 female with diabetes and the overweight versus the smoke. The correct answer is D, but that's a tough one. I mean, I can see the thought process there, but I think you almost have to do that side by side comparison. I mean, your 58-year-old is even closer than a 42-year-old. So almost by age, you could look at B and D, because this one is your youngest. So good discussion. Nice. All right, TIA we talked about already a little bit, transient ischemic attack. If you have TIAs or multiple TIAs, your risk of having a stroke increases. It doesn't have an acute infarction, so it's just a little episode. Generally lasts less than an hour, could be, up to 24 hours. And you really don't know. It could just be a one-time deal. They could have more and just be TIAs, or they could actually end up, having a stroke. And so then here we go. We've already, talked about these already a little bit, right? The classifications of strokes. And for our purposes here, even though the information's here, we're really just looking at ischemic versus hemorrhagic. We're going to talk about thrombotic and embolotic and the subarachnoid and intracerebral, just so you know the terms. But really, we're just asking you to know ischemic and hemorrhagic. And I think you'll already know what thrombotic, like a thrombus and an embolus are. So here's a picture. So here's your hemorrhagic, right? The blood vessel bursts and blood just seeps in and damages the brain tissues until the clotting shuts off the leak, right? So that's your hemorrhagic stroke. And then for your ischemic, these are the 2 different types of ischemic stroke, right? And so the embolus, right, is the blood clot that's kind of circulating, right? And then it gets someplace that's too narrow and it lodges there and blocks, right? So it's kind of the traveling one. And then the thrombus is where there's actually the clot in this narrow space here that then ends up blocking, and there's some plaque there and it forms, and so then it's blocking the passage of the blood. Does that make sense? The difference between thrombus, embolus, and hemorrhagic. And so just more definition of ischemic stroke. And here's your thrombus, right? Gives you different reasons for having the thrombus. So hypertension, right? This all goes back to that hypertension, right? And looking at the plaque formations and diabetes as a factor with the hypertension, oftentimes preceded by the transient ischemic attacks. And what's collateral circulation? Collateral?
The circulation that goes around, like the
yes,
or the whatever.
Exactly. Yes. So you get that in the heart too. So we're not talking about like heart attacks. We're talking about strokes, but in the heart, with you can get the same types of things, bleeds or blockages. And the heart's very good at building its own little blood vessels. The brain does the same thing. So if there's a blockage, or it's like, oh, this is getting a little, it starts to grow some collateral circulation. Some people's bodies do that really well. Some people's bodies don't do that at all necessarily. So that's another one of the determining factors. And then the embolus, right, where it's moving around and then lodges and includes the artery. So we're talking head, cerebral arteries. These ones are usually more sudden, right? So this is a sudden onset with severe clinical manifestations because everything was fine. It was swimming along and boom, now it's occluded everything. Whereas the thrombus kind of builds and builds and builds over time. And this is a picture here of a slice of the brain with a hemorrhagic stroke. So this would be the blood. So look at the difference even in size for the right and left side. It's pretty amazing and pretty scary at the same time. So the bleeding into the brain tissue itself, it can be at different places, different spaces in the brain. You can get rupture of vessels, right? Then if it's a rupture, it's a sudden onset. Or it could be, depending on how big of a bleed, it could be over time because it's not bleeding as profusely. But hemorrhagic strokes have really poor prognoses. And intracerebral hemorrhage usually happens during some type of activity, sudden onset, and then progression, pretty quick progression. And those are some of the manifestations that you're going to see: the headache, nausea or vomiting, decreased level of consciousness, and hypertension. And then this is just an example. This one, sorry, the picture's not bigger. You can look at that, but this shows you the different spaces, the cross section of the brain, and where the subarachnoid space is. And so sometimes you can get bleeds there as well. So sometimes when you're in an enclosed space, it's going to be this huge increase in intracranial pressure, right? And then if it's a more diffuse bleed, then you may not see that. But subarachnoid hemorrhages are pretty bad. We talked about the circle of Willis. That's where most things, where those are the majority of when we're talking aneurysms. So this is a picture of an aneurysm where there's sort of this outcropping cerebral aneurysm. So the blood is kind of making this little, I don't know, bubble, I guess you'd call it. People don't necessarily know that they have these at all. And so there is a huge mortality rate because what happens, this is an example of how you can get a hemorrhagic stroke, is that the aneurysm bursts and then you have blood everywhere. So it's kind of been compensating by making this little pocket, and then all of a sudden it bursts. 2 videos you can look at on your time. Brett Michaels had an aneurysm, so he kind of talks about his experience there. This is a clip. We're going to talk about different types of surgeries that can be done. So here's a picture. So here's the subarachnoid hemorrhage in that subarachnoid space. So it's kind of in that space there, and you'll see the increase in the intracranial pressure. And then here's one intracerebral. So it kind of spreading out all around there. Scary stuff. And you don't even know, right? You're not necessarily even aware that this is happening. So here's your Glasgow Coma scale, which we talked about earlier. Again, 3 is the best you can get, and 15 is the highest. Here's your NIH stroke scale, the National Institutes of Health stroke scale, which we showed you that already. And this shows the severity. So more dense impact for the severe stroke. There's a couple other quick diagnosing things. We talked about the FAST. They also add now BFAST, which is like balance. Are they off balance? Do their eyes look the same? There's your facial droop, your arm droop, their speech and time. There's also one developed by Cincinnati. They call it the Cincinnati Hospital. They call it the pre-hospital stroke scale. So this would be like my mom and her boyfriend at the bar, right? You know, is there facial droop? Is there an arm drift? Is there abnormal speech patterns? And then if any one is abnormal, the probability is 72%. So that's enough for me to call 911, more than enough for me to call 911. And this is some of the education that you're doing as well. Better to be safe than sorry. So different manifestations related to the location. And because there's either no circulation or hemorrhage, it's affecting the neurological function. And so it's related to which half of the brain. And then also, like we were saying for the TPA, right? The time to onset of symptoms when they have the stroke. So here's right and left brain. This is probably a key slide to memorize if you had to memorize something. So for example, so the guy's looking at us. So this is right brain. So the right brain is damaged. So the deficit is going to be on the right brain, left side. There we go, left side, right? And so stroke's on the right side. So the left side has the hemiplegia, and we're gonna forget about it. We don't even remember we have a left side. Spatial, you deny the problems, you have a short attention span, squirrel, impulsive, impaired judgment, impaired time on the right side. Excuse me. I don't know, squirrel and right have an R in them. And then left brain. So the stroke is on the left side. You're going to see the right side deficits, right side hemiplegia, speech language aphasias. So either ability to express yourself, express information, or inability to receive information. Understand the difference between your right and left sides. Slower, the performance is slower. You just kind of slow down. You're very cautious, whereas the right-sided is very impulsive. Impaired comprehension related to language and math. And the thing with the left-sided damage is that you are pretty aware of your deficits. Right brain, not as much. So we know we need to know the slide. Yes? Okay. All right, then looking at motor function, like this is the obvious thing. These are the things we can see, right? They could have trouble breathing. It's generally a mobility thing, swallowing, speech, right? We talked about the aspiration, right? And swallowing difficulties. May or may not have a gag reflex. If you can't use one side of your body, it's very difficult to take care of yourself, right? And so those are the things that you're going to see. They can have loss of their voluntary movement, which is called akinesia. It's really hard, like you can think to do it, but your body doesn't do it. What happens to your, like, what happens to the muscles when you don't use them?
Atrophy.
Yeah, you get atrophy. So a lot of passive range of motion exercises are good. And a lot of times, like when we talked about spinal cord, it was flaccid, and then like hyper reflexes, it's the same thing. So it can be really hyporeflexic and then be hyper reflexic. So the same type of thing, spastic. So it's like flaccid and spastic. And so this is an example, just so you know, so decorticate or decerebrate, when you've got the spinal tract or the hemispheres, tells you the differences in the posturing that you might see. So communication, so we were just talking about that. Aphasia, right? The stroke damages the dominant hemisphere, that affects language. So if you have, you'll hear these terms, receptive aphasia. So that means you don't, you're trying to receive the information, but you can't, you don't comprehend what somebody's trying to tell you. So that's receptive aphasia. Expressive aphasia means that you aren't able to express yourself. So if somebody's telling me to, like pain scale, right? So if you have a patient with a stroke and they have receptive aphasia, what are you, how are you going to determine their pain level? Or what are some ways you could do that?
Maybe some type of scale, like a FACES scale, or, you know, something written for them.
FACES scale, maybe. Because they can't comprehend, right? So they might be able to, you know, if you show them a FACES scale, they could probably figure out, you know, what you're asking them probably.
Would it be more like the nonverbal cues?
Like physical cue, yeah.
Yes.
Sorry, I thought you were asking about the expressive.
Oh, I'm sorry. So I'm like, oh, I don't really think that's going to work for receptive. Yeah, so receptive is going to be more your observations. Yes, a flack or, you know, yes, yes, yay. Okay, now Shannon, expressive. If it's expressive aphasia, so they can't express their pain, what would you do? Say what again, what you would do?
Like a FACES scale or something written that they can maybe point to or something.
Because they can understand that you're asking about their pain. So then maybe you could have them point to a number or it's some kind of rating scale you could give them. They just can't say what it is, but they totally, and that I think is got to be the worst, right? Because you understand what's going on, but you can't, you're like, I feel like you're trapped, right? So that's got to be bad. But you could, for expressive, use some type of pain rating scale. And then if it's global aphasia, there's total inability to communicate. Dysphagia is just another term referring to not being able to communicate. So different, you know, in how you pronounce a word, how you articulate it. Sometimes it's kind of slurry. They may interchange sounds or words. Affect is really, you know, when you suffer a stroke, it's really difficult to control your emotions. And then if you have depression, there's, you know, your body's changing, right? Your function, being able to communicate, I just can't even imagine. Memory and judgment can be impaired. Just remember that some are dependent on the hemisphere. So the stroke on the right side is more likely going to cause spatial perceptual orientation issues. So you don't understand, you don't know where you relate in space. You get the unilateral neglect of the affected side, right? You don't even like know that side exists. I have a picture of the homonymous hemaniopsia. Apraxia, right? Motor speech, agnosia, so that you like don't comprehend. And then, oh yeah, here we go. I knew I had pictures someplace. Yay. So agnosia, like loss of ability to recognize a person. Like you would think, oh, well, this is their spouse, but they don't recognize their spouse because that's the type of stroke they had. And so they're like saying, I don't know who you are. Aphasia, right? We just did that. Difficulty expressing or understanding. Apraxia, right? That's the motor speech piece, like getting your mouth to actually move and say the words that you want them to say. And then dysarthria, right? Arthria, motor speech disorders, weakness, slowness, poor coordination. And then this is your homonymous hemaniopsia. You know, these words are killing me today. So if you have a left cerebrovascular event, a stroke on the left side, what it's going to do is you are going to you're going to only see on the one side. I think I got that right. Yeah, left field, right field. And so the in both eyes, you can only, I believe the purple is the side that you can see from. No, that's the side that's blocked. So you're only, if you look at your right eye and your left eye, you're only going to see the left side. You don't see anything on the other side. So if it's a left stroke, it affects the right side. So left stroke, right side. So that side's blocked. It's only, you can only see the good side rather, right? So you can't see the affected side. So that's why that ends up being unilateral neglect. Did I totally confuse you? Because I confused myself, right? Left-sided stroke affects the right side. So the right side loses vision on both right sides of the field of vision. So you can only see the left side. Your right side has the hemiplegia, but I can't see it. I can only see the side that works. And so that leads to the unilateral neglect. And so if I can't see out of the right side, where are you going to put things if you're trying to teach me, if you're trying to set me up for my ADLs or to eat?
Left side?
On the left.
On the left. If I'm walking up to the patient to talk to them, what side am I going to stand on when I'm talking to them? Left side,
Left.
right? The left, yeah. Now I may touch them on the right side. I may move a little bit more, you know, back and forth, because I don't want them to neglect that side. So we're gonna have to do a little bit of PTOT, have them come in and evaluate and work with that. Elimination, not as many problems like we had with spinal cord with the neurogenic bladder and all that, and that was like long-term sequelae. With the stroke, it's not, they're usually, issues are usually temporary. So that's nice. Okay, so diagnostic studies. Why are we doing the diagnostic studies, right? We need to confirm that it is in fact a stroke. And then the cause, meaning is it the hemorrhagic or the ischemic, right? So you guys got that one right. We're gonna do the CT. You can check for heart problems. You can do blood tests, liver, kidney, your prothrombin times and INR, which you will learn more about in third semester, but basically it's bleeding times, how long it takes the blood to clot, because we would like it to clot fairly quickly. So if somebody's, hopefully, if you're on a blood thinner, you don't have a stroke, but if you have a stroke and you're on a blood thinner, that's scary. Other tests you could have: Dopplers, ultrasounds, angiograms. I have a picture of an angiogram. Yeah. So this is a picture of an angiogram that shows some stenosis. So stenosis is narrowing. So see an A here. See, that's like how it's supposed to be. And then there's this narrowing. And then they did an angioplasty. So they kind of opened it up a little bit. And then it recurred again. And then they put a stent in. And so a stent will help keep it open. Sometimes they'll do a lumbar puncture that shows you about positioning for lumbar puncture. And then myelogram, that's another one. I don't really worry about the CT is the main one to know. Let's put it that way. And then so different surgical techniques in terms of the aneurysms, these are different types of clips, and you basically can clip the aneurysm. And then hopefully eventually you could tie it off, or you can do the coiling. This is a coiling. And so you can coil. And so it blocks the flow into the aneurysm so that it doesn't rupture. So if you look at the aneurysm, right, remember I said it was kind of like it was making this little bubble. And so the more that it makes the bubble, it's going to get bigger and bigger and explode, right? That's the aneurysm. But if we could clip it like we did here, or if we can coil, and so it's blocked here, then it can't get bigger and burst, is the thought behind that. Another type of surgery for stroke patients would be, hopefully this would be prior to having a stroke, but you could have what's called a carotid endarterectomy. So where they actually go into the carotid arteries, and I say roto-rooter, but go in and get all the plaque out so that the blood flow is still continuing to the brain. And so you can put stents in as well to keep it open so that the blood flows through there. And what's kind of cool is that, like, when they pull out the plaque, it's like in this little chunk. It's not like little pieces. It's like this big, yeah, it's gross. And it's a pretty, I wouldn't say safe, but they're doing it on outpatient basis now. You know, you go in, it's a same day surgery. My husband actually had one on each side. The first one he got, his blood pressure skyrocketed and they had to give him some medication to bring it down. He ended up staying overnight, but normally it's you go home. All these questions, all these stories about my husband, sorry. And then if you can't do the endarterectomy to roto-rooter it out, then you can put the stent in. And we talked about TPA already. This is that same link that will take you to that article for the neuroprotective agents, right? You've got your heparin and warfarin. So heparin, would you give heparin at home? Like if you're getting ready to send the patient home, would you send them home on heparin?
No.
What would the plan be to send them home?
Warfarin.
Right, and so there could be time. Could there be a time when they're taking both?
Yeah.
Yes.
Because why?
You want
Because they're getting ready to be discharged.
But they're getting ready to be discharged. But why are you overlapping a little bit?
They're transitioning to discharge as well as because the one is shorter acting as opposed to longer acting.
Yay. And which one is shorter and which one is longer?
Heparin is shorter.
Heparin's shorter, right?
So when you have somebody, and Coumadin is the other name for warfarin, when you start them on Coumadin, on warfarin, it takes a while for it to build up in the system to be effective. So if we're giving heparin and the doses, will be titrated, but you're giving the heparin to sort of cover, right, until the warfarin gets to the therapeutic amount, which we know by doing blood work. We do the PTT and figure out the INR to see how the clotting is. So you could have a patient that's on both as you're trying to get them onto the correct dose of the warfarin. Does that make sense?
Yeah.
Okay, because people will be like, well, why are they on both? Well, because they have different actions and we're trying to get them to a certain place. Oral or IV, antiplatelets, irrigation, same one I gave you earlier. Okay, I think that covered, I think we got through all those. Do you feel like we got through those? I feel like we got through those.
Ms. Solinger, I have a question before we move on.
Yeah.
So for the unilateral neglect of the affected side, does that occur in both right-sided and left-sided, or just left-sided? Okay, so it's
because you're not using the side.
Okay,
like,
so whatever the affected side, they won't see the affected side. Is that
depending on where? You don't always. It depends on the sensory perception deficit, so you won't always get that. Depending on where the injury is, but it would be neglect of the other side because you're not really paying attention. If you can't see it, then you forget about it. But not always is the vision affected that way.
Okay, so it could happen in either side, but just depending on what's affected. Okay, thank you.
And as nurses, we're not necessarily concerned with how it happened, right? We're going to do our assessment to find out or we're going to be told in report, right? Like what their visual acuity is, what their deficit is, what side it is, and then our interventions are going to speak to those, if that makes sense. Okay. I think I'm going to go through this one and then hopefully this won't take too long and I can let you guys go. Okay, so rehab, right? So talk to me, people that are in ARU, right? Talk to me about what you're seeing. I know Aaron had shared something. What are you guys seeing in rehab, either with PT or with your patients? What are some of the priority things that you're working with your patients?
So on my therapy day, I actually followed one of the PTs, and he was helping a woman who had a right-sided stroke.
Mm-hmm.
The big thing with her is not only was her left side, you know, she didn't use it, didn't know it was there.
Yep.
She thought, so her spatial awareness was off, like you mentioned. So if you're sitting up in bed 90 degrees, normally you think that's straight up and down. She was at 60 degrees, thinking it was straight. So it was constantly like moving her up. So not only she can't use her left side, but she's also at a high risk for fall because she thinks she's, you know, straight up when she's not. And
I
so
have a picture of that. Yeah.
what he was doing was kind of cool. I mean, he was constantly reminding her to use her left side and you know, asking her, okay, where is it? Where is it? Because she would want to sit on it or roll on it. And during therapy, he actually picked her up and was like, well, not picked her up, but helped her stand up and was kind of wedging her against the wall on her right side. And going, no, this is straight up. This is straight up. And kind of walking with her to, and kind of reorient her and kind of retrain her brain to know this is actually up.
Lot of retraining.
Yeah.
This is kind of a picture, an example of that. She thinks she's sitting straight up, but she's really, you know, she's really not. What have other students seen? What else are you seeing?
I haven't worked with PT yet, but my patient last week was post-stroke, and I didn't go with him to physical therapy, but he was working a lot with his ADLs and like trying to improve with his own care before he could go home. So it was a lot of ADLs and being able to make sure that he could help himself once he got home.
Right, self-care management, right. Right, independence. You want your patient to be as independent as they possibly can. Right, that's always one of our goals. What else? Anybody seeing other stories to share? Anything for those of you maybe that hadn't worked with stroke patients before or knew anything about it? Anything surprising or you didn't even think about? Okay, so we will move on to this one.
I think sometimes they train them about safety to cause with the affected side. They're not able to feel heat or cold. So they work a lot with them about it so they cannot hurt themselves.
Right, because if I can't feel if it's hot or cold and my finger's on the burner, the connections aren't there. Yeah, scary. So are the patients that are being discharged from ARU, are they being discharged home or to a rehab facility or both? Do you know?
The plan of care for the patient I was working with was home, but I think it's a combination of both, just dependent on where they are in their care.
Exactly. Okay, sounds good. And so when we were in long-term care last semester, we were actually on the long-term care side, the people that kind of are living there, but the other side was the acute care, and that's where they're doing the rehab, and a lot of those patients are. So you are going to see those types of patients in a long-term care facility. And you're trying to get them as independent as you can. I want to say PT works with them maybe once or twice a day, and then maybe not on the weekends. It kind of depends on the facility and what the physician's order is, because the patient gets tired as well. And so our teaching, the return demos, you know, evaluating that coordinating piece in those care coordination conferences to really let everybody know where the patient currently is in their progress, in all aspects, you know, patient, family, physical, mental. So this nurse, they're doing improving some arm strength there with their little weights. And then, so what's the difference between PT and OT?
OT is more of your like ADLs.
Mm-hmm. And PT is kind of the strengthening so that you can be able to do the OT, right? The ADLs. Yeah. And so sometimes you'll even see they'll have, I know at the Ridge, they actually have the room has a kitchen in it so that they can practice cooking, or like you're saying, hot and cold, and you know, practice baking or cooking or getting things out of the refrigerator or whatever. You know, they have like literal setup, a kitchen setup, which I thought was really cool. And then looking at mental status, cognitive status. And so we're looking at all in the rehab piece, we're looking at all this, you know, what is the potential, right? Based on the type of deficits that they have, the type of injury that they had, what is their rehab potential? You know, where are they physically? Are there other comorbidities that could be a problem, like diabetes, you know, probably already have hypertension, but diabetes or other things. And then looking at, if you're looking at the getting ready to discharge, which would be the Boost tool, which you actually have on your care, I think it's a care coordination one where it lists like health literacy and socioeconomic status, those types of things. So that's what you're looking for. Do they have the support systems that they need? And here's your homonymous hemaniopsia, right? So right, and so if it was over here, they don't even know it's there. They can only really see what's over here. So he's going to have a lot of pepper and no salt. So what are you going to teach the person to do to be able to see the other side?
Do like the scanning technique where you turn your head.
Yeah, nice. You know, there's your ADLs working on walking. Sometimes it might be with an assistive device, some kind of walker. So hopefully the muscles have become a little more, not spastic, but you don't want them to be, they say flaccid for a long time, it's harder to regain the motor function. We don't want them to lose more. We want to say them, we want them to keep moving forward. And oh, I know what I was thinking. We had a patient, let me go back. Was it that one? I think it was that one. Oh, I can't remember. We had a patient that presented to Shrine when I worked at Shriners on the spinal cord injury unit. We had a young man who was 18 and had been in a gunshot wound. He was shot by another team up in Alaska. And so we had come to our facility and for rehab, for Shriners for rehab. And when he came to us, he could not walk. When he left, I still remember being there because they had everybody that had ever cared for him in the room down in PT. He walked out of the hospital. Like he rehabbed because it was actually a partial and had a lot of inflammation, which people didn't realize, but he worked so hard that he was actually able to walk out of Shriners. It was amazing. The things with rehab and hard work and dedication and recognizing and evaluating and all that kind of stuff is amazing. You know, working on balancing, transferring. You have to be careful when you're the nurse, right? You need to be careful for your own safety when you're transferring and moving these patients, right? And so there's a little thing about the constraint induced movement, just FYI. And this video shows a person that's able to walk after stroke. I think it's about a 6 or 7 minute video where the person's actually going through the rehab and then increasing their mobility, which is amazing. Different assistive devices. So sometimes you only, you know, the hand doesn't work all the way, or you have plates that have edges. Yeah, falling and hurting your back, exactly. they have, so these plates, it's not a bowl, it's really a plate, but it has an edge. And these are little plate covers that you can put on. And so they're going to kind of move the food to the side and then scoop it up. Adaptive silverware, the cup that you can kind of grip like that. So what are some things you can do to protect yourself when you're moving a patient or transferring a patient?
You can use a gait belt and then check their assist and how many people per assist, and if they need assistance or if they need any kind of equipment to help with assisting.
Right. So what if they're a one person assist, but you're like, I don't know if I'm the one person to do that.
I'd ask for help.
Yeah. Ask for help. How easy is it to find a gait belt? Unless you have your own.
Hard.
Right? I can never find that. Rotate at the hip. Yeah, rotate, right? Not with you have to go back to all those body mechanics. I would always call for someone to help me, right? But Amanda's, point is taken that what if they fall, right? And hurting your back. So what happens if the patient starts to fall?
Head them to the floor.
Yeah, you just kind of go with them to the floor, guide them down. Yeah. Yeah. Hoyer lifts, all that. Assist them to the floor. Yes. Although I will say, I think Mai and I did a nice job with Our Lady in OB. we didn't need Hugo or Francisco, did we, Mai? We did a good job. It's all body mechanics. Yeah. So you'd want to go down with them, but not like bend over, like try to keep your body mechanics as best you can and just, keep them from hitting their head on something, that type of thing. You might need bowel management programs. They might need catheterization at some point, but hopefully they're going to regain all that function. Lots of fiber. When it's emotional, it's really difficult. And sometimes you have to, we're not talking about traumatic brain injury yet, but in a patient with a brain injury, they'll have these like emotional or like angry outbursts, or they'll say things to you. It's almost, I don't even know what it's similar to, but so you can't take it personally. You're not going to reprimand them. You're going to try and use distraction techniques or, explain that to the family that this is unfortunately for right now, this is an expected response. So, try to maintain a calm environment, maybe bring it to their attention. They probably don't even know that they're doing it. So I think that's another more difficult aspect. And then we were talking about caregiver role strain, right, as one of our client problems, right? So the person themselves and their support people, like it's loss, it's grief. I've lost function. I've lost my former self. And so there's that grief process. So hopefully there's some support groups. Hopefully they have a support system. I've seen some people, where was that? I think that was Pacific Coast Care. We had a gentleman a couple years ago who was homeless, and so, and the facility, they were trying to find a place for him to go. And I'm not sure where he ended up, which is really sad. Try and assist with the coping, keep things, kind of let the family know and the patient know kind of what's going on, the lifestyle changes. Again, not something you're going to do like we did with the spinal cord either, right? You're not going to do that the first day or two, right? We're talking rehab now, right? We kind of have a better picture of what their deficits, are long-term. They're doing physical therapy, and always include them in the planning.
Ms. Sullinger, I think having worked with a lot of these patients, it's important not only for the nurse but for the family also to realize that sometimes you have to kind of keep the patients within a certain limit, because I've seen a lot of times where patients try to overdo their rehab, and I've seen patients have literally go backward when because they're trying to reach a certain goal that isn't within expectation. And I know obviously families sometimes want to encourage, and hey, you'll be walking soon and XYZ, but you know, just having that, knowing what they can do at the time and not trying to push them too hard, I think is important.
I think that's a great point, Raul, because I think sometimes people think, oh, well, if I just do more reps or do more of this or go, and it doesn't necessarily, it's like bodybuilding, right? You're only really supposed to do so many sets with so many reps to get to your goal. And they get tired. And then what about nutrition, you know, and hydration and all those other things. So that's a great point, Raul. Thank you. Right. Some things may or may not be changeable when you're talking with the families. You know, you don't want them going back to old habits either. So hopefully you can talk with them and the family about that. Support groups, which now during COVID, I guess that would be by Zoom, or maybe, do they have in ARU, do they have any patient support type groups or anything like that? Probably not right now.
Not that I've seen.
Because I know in mental health, they'll do like group. They have like group every morning where like everybody gets together. I don't know if they're still doing that, but I know in mental health, they do that. And then, you know, sexual function, we talked about that. That was in your case study with SCI. That's, you know, can be a concern. So trying to be open about that or getting resources for that. And then being able to integrate back into the community, which right now would be really difficult with COVID, but, you know, resources, transportation is huge. You know, if they need Meals on Wheels or something, trying to identify any and all resources that are available to them in their community, which is a you know, thing that a nurse, the case managers can all help with. And so for the older population, the gerontological considerations, you know, if the gentleman is 70 years old and had a stroke and he's married, how old is his partner potentially?
Around the same age.
Around the same age. And so what are their capabilities going to be to provide care for the patient?
It's going to be a lot harder.
Could be a lot harder, could be, you know, could be fairly limited, depending on their health, you know, if they have hypertension or blood pressure problems or, you know, so then you're looking at, well, is placement in a long-term care facility? Are you going to have a caregiver come into the home? Like you have to look at all those things. Again, is the bedroom on the second floor? Maybe we have to rearrange the house and the rooms. It's a lot of changing needs and adapting and the family. And that causes a lot of stress, I think that was the last one. Yep. So that was pretty much all I had. I think we went through everything here. That was my intent, to go through all the objectives. What are some ways that like that you could help if you were the patient or if you were the support person? Like what are things that we as nurses could do to assist you? It's kind of like that question we had on the SCI case study. Like what would be helpful for you, or if you're in ARU and seeing this, what are caregivers finding helpful?
Make sure that they're, like, if they have a lot of responsibility in terms of helping out the patient with their, you know, with everything that they're going through, skills, what we would call skills, right, or whatever, making sure that they have said, like, okay, yes, I feel comfortable doing that, you know, making sure that we've taught them enough times, that we've answered their questions, you know, we need to know that they feel that they can handle it.
Yeah, no, I think that's, yeah. And they may not know. I think that's why in rehab, it's probably a good idea. I don't know if you do rooming in the NICU, we do rooming in, but active listening. Yep.
Important. I think
I'm just reading the comments. Yeah, go ahead, Shannon.
I think it's also important to make sure that the client themselves is comfortable with the caregiver doing certain things, because if it's a spouse or whatnot, they might not want them, changing them, or, whatever the case may be, they might be uncomfortable with something.
Right. I think those are all great comments, right? The self-care, caregiver self-care, community resources, the DME, the wheelchair, all that kind of stuff. You helped a woman, Amanda says she's helped a woman who had Parkinson's. Right. I mean, sometimes just having the positive attitude or being supportive is great. Available resources, all good ideas. I think it would probably be important, like Raul's saying, caregiver self-care, but it's one thing to say, well, you need to take care of yourself. And then it's another thing to sit with them and say, well, let's figure out some ways that you can take care of yourself, right? To try and give them some suggestions or what works in their schedule. Okay, so that was what I had to cover. I think we covered our key points. I think I covered things that you're going to need to know for the quiz. And I'm good if you're good, unless you have other questions. I'll post the link in the announcements for the retake for 1:30, and I think we're good to go.